Good afternoon. Good afternoon, or good morning, or good evening, wherever you are. Very welcome to this interpretation workshop on BRAF. So my name is Emilia Andersson, and I'm here with my colleague Ann Weidelich. We're both Roche employees and very proud sponsors of these educational sessions provided by CADQAS. And we will listen to Corrado and Adelina Baltan to talk and really discuss around BRAF, immunohistochemistry interpretation. So this is an invitation to you all to take part and share your experiences as well. BRAF can be used in many different indications, and we would love to learn also from your experience where you're using it. So, but with that, I will give the word back to Corrado and Adelina.
Thank you very much, Emilia. It's a great opportunity today to talk about this immunohistochemistry, because it's been around for the last maybe 10 years. And I always thought when I first came across it, that was the most exciting thing that happened to histopathology. We could see with our eyes the mutant protein. I thought that was really powerful. Okay, so the workshop is really to try and put a little bit of order into the use of this antibody and also the context in which we want to use it. And these are very much my notes. Adelina may or may not agree with some of the things I will say, and I'm very happy to hear people making comments and actually or telling us that their experience is different. We've been using this antibody, I think, more or less since it was available, so about 2009 or 2010. So I thought that before we look at pictures and interpretation of the immunohistochemistry, we'll speak briefly, well, not so briefly because you know me, about the context in which BRAF functions, and that is the MAP-ERG pathway, signaling pathway. So MAP-ERG signaling pathways is one of those pathways that transfers some kind of signal from the extracellular environment into the cell, and then there are lots of little words that I've abbreviated. The MAP kinase that we refer to actually is called mitogen activated, originally mitogen activated protein kinases, and ERK was the name given to these extracellular signal regulated kinases that are all downstream here. Of course, those of you who are a little bit longer in the tooth will be familiar with the RAS and RAF, because these were proteins at the beginning identified through the study of these cell lines or explants from virally really induced tumors in animals. So RAS is because it was activated, it was present and overexpressed in a experimental model that had a sarcoma virus as a driver, and RAF was the molecule into these fibrosarcoma cell lines that were expressing it very rapidly. Okay, so any protein kinase receptor, in this case EGFR, but it could be anything else, function more or less under the same principle. So there is an inactive form of the receptor, is a monomer, and the moment it is engaged by the ligand, it hinges out and reveals this yellow portion, and the yellow portion is the dimerization site. So once it's activated, the two dimers can come together and make a close proximity pair dimer, and this means that these two intracellular portions are close together and can become phosphorylated. So the phosphorylation, and there is not one phosphorylation site, there are many phosphorylation sites, but they need this proximity. Once the dimer is formed, then phosphorylation occurs, and then there is a downstream activation of this cascade. So there are some accessory molecules, which are not that hugely important to this discussion, that recruit RAS. RAS is a small GTPase, and then RAS can activate the first of a series of protein kinases. And the first protein kinase activity is RAF. And then RAF activates MEK, and MEK activates ERK. They form complexes, and they activate these things. And then these are my annotations. There are various names for various of these molecules along the way. So this is the kinase cascade.
Yeah. And I think it's very interesting that you put this together, because this explains, if we look at how the evolution of treatment development as well. And now, for instance, we're trying to use MEK inhibitors or ERK inhibitors in like carcinoma of unknown primary, that is more downstream of the pathway.
Of this pathway. Okay. So obviously, these protein kinases activation, these receptor tyrosine kinases, which are many, they eventually activate this cascade of transcriptions, and but they also have alternative pathways. The most well-known is the AKT alternative pathway. So it's not just one pathway, but there are others. Nevertheless, so if we stick to the RAF, RAS, MEK, ERK pathway, the players are not just RAS, because there are three, well, there are more, but in humans, these are the three most commonly recruited GTPases. That's HRAS, NRAS, and KRAS. There are three RAF members, ARAF, which in Wales means something else, BRAF and CRAF, and then there are at least two MEKs and two ERK. Cool. So if we look at RAF, which is the subject of our endeavor at the moment, so there is ARAF. ARAF is so these are all in the same family, and they share a lot of commonalities. There are many other RAF members of this family, but not in humans. And ARAF is the one that has the lowest kinase activity towards activating MEK. And everybody suspects that this molecule has got other functions, but it's not entirely clear what the other functions are. But that's kind of important as well in our discussion on why mutation in BRAFs can cause strange effects, and especially the interference of the BRAF activated mutated by tyrosine kinase inhibitors. So BRAF can form homodimers, BRAF, or heterodimers, and the most common heterodimers will be with CRAF. So CRAF can only form heterodimers. It doesn't dimerize with itself. And KSR1 is the other partner. They can do it. And interestingly, while activated mutations do exist in CRAF, actually, they're not very, very common. Actually, they're not common at all in human cancers. So not sure why, but in reality, most of the RAF mutations occur in BRAF.
Yeah, and in the pathogenesis, so is there, but CRAF participates then in alterations?
Yes, it participates, and we will see in a moment, because of the ability or inability, because of certain mutations, of BRAF to form dimers. So the gene located on chromosome 7 encodes for the BRAF protein. The gene has essentially, well, encodes for three different areas, has three different things called CR1, CR2, CR3. CR3 encodes for the kinase domain. There is a hinge region. Hinges are important in enzymes. This is an enzyme, because movements of these relative parts enable activation or non-activation of the enzyme, but also dimerization or non-dimerization, a lot of other things. And also the other thing we need to understand is that the BRAF doesn't really only interfere or make a complex with MEK, but it makes a complex with a lot of other things. So parts of the molecules are involved in other functions. The CR1 domain has the autoimplicate domain. So constitutively, this molecule is built to be self-inactivated. It's folded in a way in which it cannot function. And then perhaps a RAS binding to RAF and donating, activating is a GTPase, so then can unlock the inhibitory domain, and then the protein kinase domain becomes active. In here, there is the RAS binding domain as well, and there is the dimerization domains are here as well. So let's move my picture here. Interestingly, there is a syndrome that is based on the fact that it's a germline mutation. There are always germline mutations, and sometimes we don't hear about it because they're very, very unsuccessful mutations. That is, the development doesn't occur or occurs very badly. And in some individuals, there is this, that they have BRAF mutation, germline mutation, there is this craniofacial cutaneous syndrome, dysmorphism, mental retardation, etc., etc. The interesting point about this is that cancer is not one of those things that these people suffer from. It's not a very common syndrome. I don't know about numbers. It could be just because they don't live long enough. I don't know. But interestingly, they're not full of tumors. But the largest contribution is made by the somatic mutations, and they are found in both adult and pediatric cancer. They are found in solid tumors and liquid or hematological malignancies, and they do not, by definition, make a tumor more aggressive or indolent. There doesn't seem to be a logic to it.
That's an important point, I think.
Yes, but also because there are many, we will see, 200 plus known mutations in BRAF, and because of the multifunctional way in which BRAF functions, it is very difficult to understand what would cause what, what mutation would cause what effects. So in human cancers, overall, this is the figure I found. So 6% of all human cancers have BRAF mutations. It doesn't mean that these are the drivers, but they are there, and principally is in the kinase domain. And so over 200 oncogenic mutations. And a lot of these oncogenic mutations are targetable, but not all of them. Oops. And this is the translation of the kind of heat map, if you want, or place where all these mutations are. And of course, the ones that are most important are in the kinase domain, and this is the kind of blown up things, but they're distributed all over the molecule. Now, there are 3 different classes. It's that interesting. Humans classify everything. This is we are built. Our brain is built for classification.
That's how we work.
That's how we work. So here it is, a classification of BRAF mutations, class 1, class 2, and class 3. So class 1 is really only in codon 600. And what happens is that the kinase gets activated in a RAS-independent manner, and the molecule functions as a monomer. It doesn't need to dimerize, okay? The class 2 molecules instead is non-600V, still has strong kinase regulation, activation, but it needs to dimerize. So what does this mean? Is that if we can't dimerize, doesn't matter that this kinase is activated because it doesn't work. And is independent of RAS again. So both of these are independent. Basically, the mutation has caused kinase activation, but in class 2, you need to dimerize, otherwise you won't activate downstream. The class 3 is kinase impaired, or mostly kinase impaired. So that, why will something like this cause cancer? Because it doesn't transfer the signal, the cascade signal. But so first of all, it now needs mutated RAS. Okay, so these class 3 mutations are only really worthwhile if there is a mutation in RAS. Also, you need to dimerize to do that.
Okay, but because it dimerizes with CRAF, usually when we have a RAS mutation upstream, would it not, kind of signal to RAF in any case? Or
it could, but what happens if RAF is mutated?
Like, as in,
well, the interesting concept is this, that we know that class 1 and class 2 are usually the unique mutations. So if this RAS is mutated in class 1 or 2, you don't have RAS mutations. But instead, for class 2, 3 mutations, because you need RAS, is the paradigm is no longer valid, or if you have RAF mutation, you don't have RAS mutation. Actually, in these tumors, you do have RAS mutation if this mutation is oncogenic, because otherwise it doesn't function. And as you said,
that's the driver usually, the RAS.
And interestingly, the supposition is that this dimer signal through RAF, CRAF, not through the kinase. The signal that goes ahead is CRAF kinase. Okay, so a few more annotations. The class 1s are sensitive to targeted RAF inhibitors. Class 2 really probably need dual inhibition of RAF and the downstream MEK. And the class 3 is completely oblivious to any inhibitors that we could give them. And I don't know whether this is correct or not. I was very, very surprised, but more than 90% of all BRAF mutations in human tumors are V600E. That's amazing.
Yeah,
okay.
This sounds like a lot, but some tumors are defined by this, quite a few of them.
Okay, how are we doing for time? Not bad. Okay. Few more thoughts about this V600E. This is not the only oncogenic driver. In fact, on its own, it doesn't really do very much. We know that a large proportion, I'm not entirely sure that it's 80%, but I would say maybe 60 or 65% of benign cutaneous nevi are, harbor this mutation. And in benign processes where there is this mutation of BRAF, this actually drives senescence because it induces P16 and therefore stabilizes and arrests the cell cycle. That's kind of interesting. But in malignancies of the same type, these mutation becomes oncogenic because there is now hits at tumor suppressor genes important, like CDN2A or P10, etc., and only after the tumor suppressor gene mutation, then you have a hit in this in one of the genes in the MAP kinase cascade, for instance, BRAF. And also the other interesting concept is that BRAF itself will induce senescence. But if the cell manages to learn how to reactivate telomerases, and we know, for instance, in melanoma, there is that promoter mutation in the promoter that restores telomerase activity, then you overcome senescence, and then you may become, the whole configuration may become oncogenic. Okay, and given that we are in classification modes, there are different types of BRAF inhibitors. And I knew them as first generation and second generations, but actually they do different things. Just for us to remember that they have different abilities to hang on. So these are tiny little molecules that engage mostly the active enzymatic site of the tyrosine kinase domain, and don't let go of it because they have very high affinity. And therefore, because the tyrosine kinase domain is engaged, it cannot go and stimulate MEK or something because it is already engaged. So the type 2 inhibitors have better affinity and fewer side effects. So they inhibit fewer tyrosine kinase, other tyrosine kinases than type 1 inhibitors. And then, of course, in the realm of treatment of the BRAF mutant tumors, they learn very quickly that often, and this came from the melanoma experience, often tumors may respond very well to BRAF inhibitors in monotherapy, but then very soon, within a year or so, the tumor evolve a mechanism of escape that doesn't respond anymore. And they found out that if you inhibit also MEK, you have a longer, more durable responses and so on. Okay. So these are some data that we have already spoken about. Okay, so I was kind of trying to think what we would like to know about BRAF. So first of all, let's talk about how we test for BRAF. Sequencing by whatever method you want to do. And I put the pro and con here, which are not really exhaustive. You can think about others. So sequencing means I will detect any mutation. I don't have to know exactly what I'm looking for. Whatever is there, I'll detect. It has longer turnaround times, high costs. It's for most of us is not implementable in house. For most of us, it's a send away test. And importantly, you have to grind, and therefore you lose the microenvironment. The positional informations are not there. So another way of doing it would be by PCR, either qPCR or dPCR, more sensitive, it doesn't matter. But that means you need to know what mutations you're looking for because you have to have the primers for the mutations. But that's fine because, as you saw, 90% are BRAF V600E, and then all the others are covering probably 99%. So you may be missing an extremely rare event, so it doesn't really matter. The turnaround time are much shorter, and it is a technique that is more easy to implement in-house by histopathologists. The cost is medium, and again, you still grinding it, so you don't know microenvironment.
That's a big problem because we know in both, I would say, colorectal, also in melanoma, we can have benign component or adenoma versus nevus in melanoma that have different profile for BRAF.
And in fact, we have had cases, very nice cases, where the coexistence of a benign nevus and a melanoma, when you stain it for BRAF, you realize the nevus is BRAF mutated, but the melanoma is not. But if you grinded it, you probably would have told you it's mutated.
Mutation, and then
Okay, these are not common cases, but nevertheless. So the third method would be by immunohistochemistry. There is the Spring clone V1. I can tell you there are other clones that are not very readily used by immunohistochemistry because you need to do a hell of a lot of work to understand how to antigen and retrieve these other clones. So instead, the Spring clone is worked out. So it's very useful for us. The turnaround time are short. It's an immunohistochemistry. The cost is lower, but not as low as we would like because these unfortunately are classed as high medical value tests and therefore expensive, although it's an immunohistochemistry. It is easy to implement in-house. Anybody that has an autostainer will be able to do it, and it enable you to study the position, to give position information. I think that's very important. In the cons, it's only detect one mutation, although we heard that it is very common, but nevertheless. And you need to know how to interpret, and possibly we will go through some examples now in this course of this presentation. So there have been several publications that put in question the specificity of the V600E antibody. And I've read them all with great interest, but my I can refer to you our own experience. We've been using this antibody for more than 10 years. We have hundreds, maybe thousands of cases. We have series where we've also sequenced the tissue to correlate the findings. Other people have done the same. For instance, this is a study with over 100 cases, which has been cross-referenced by sequencing. And like our experience, we do not have cases that we think are immunohistochemistry positive and they have no mutation, and vice versa. So if there is a V600E mutation, we find it, and we don't fire off diagnosis of V600E mutant when there isn't. So I know that there are papers there that say, they talk about cross-reactivity, etc. That's not in my experience and the experience of others here. Okay, how do we use this antibody in the context of our jobs as histopathologists? So three main areas. One is the prediction of response to treatment. We spoke about it. If there is a V600E mutation, I can give a tyrosine kinase inhibitor, could be useful for treatment. The second is that identification of this mutation may stratify patients' outcome. So it's a prognostic category. And the third one is diagnostically. You know, we now increasingly use this as a diagnostic tool when we want to confirm or dispute a particular histological diagnosis. And this is not an exhaustive list. In fact, as you probably have heard in the previous part of this presentation, low amounts of low frequency of BRAF mutation occur essentially in all solid tumors and hematological malignancies. These ones here are a list of tumors either because that we know about, either because we work with it, or because these mutations are very frequent, so it's worth flagging it out. So melanoma, and more particularly cutaneous melanoma, because we know that mucosal melanoma and uveal melanoma they have different drivers. But in cutaneous melanoma, the two areas of use is therapy selection and diagnosis. And this is a scheme that Adelina passed on to me to say that we are now changing the way in which we interpret these challenging melanocytic proliferations, cutaneous melanocytic proliferation, where there is this question mark: is this a Spitz type of cell tumor? Are these tumors with inactivation of BAP, or are these tumors that are now in this broader spectrum of deep penetrating type of lesions, et cetera, et cetera? So these melanocytomas. And because, of course, for all of these tumors, the differential diagnosis are melanomas that masquerade for one of these entities. And while the diagnosis is very easy when you have satelloidosis and metastasis, when you don't have any of these and you are faced with a single section, you may want to use some of these techniques.
Yeah, we need to make note that this shows you the pathway of melanocytic lesion, like Corrado said, versus usually spitzoid. So usually the day-to-day challenge, they are BAP inactivated or other PEM or other rare melanocytic lesions, but usually is with Spitz, the struggle, trying to understand, is this a Spitz lesion with atypical or melanoma? But in any case, we have to understand that there can be intermediate prognosis lesion that are BRAF mutated. So again, that doesn't tell us necessarily that this lesion has a malignant potential. But then if we suspect some other pathway and then the lesion is BRAF mutated and it looks in a particular way a bit more ugly, it has some mitosis, then we can go down if it's intradermal, we can basically classify it as melanoma.
And you can see here in this schema thing that BRAF is used to try and understand what are the chances. What he's saying here, Spitz tumor doesn't have BRAF. This is not 100% true, but the greatest majority of Spitz tumors don't harbor BRAF V600E mutation. So if your differential diagnosis is between a spitzoid melanoma and a Spitz tumor, and you have a V600E mutation, this is a heavy pointer that tells you, maybe this is a melanoma rather than a Spitz tumor. Also, if you think perhaps you can think about a deep penetrating nevus or a Spitz tumor, again, presence of V600E can help you sort out this category. This is just an example. And obviously, these are all thoughts in evolutions because the molecular classification of these lesions are now being refined. Don't remember what this is. Okay, so these are, let me just go forward. Okay, these are two tumors, two cutaneous tumors. I'm very sorry, I think I messed up the animation here. This is kind of final, where there are two tumors in the same individuals, and both of them have this morphology. They're invasive, and this one is ulcerated on the right-hand side, and both of them express V600E, and they are both V600E positive. Here is another example of a nodular melanoma that is V600E negative, and on reflection with qPCR, there is a mutation of position 600, but it's R. So this is an example to say, if you use V600E in your prognostic repertoire for melanoma, a negative V600E doesn't mean this is not a treatable tumor, because there are rarer mutations at this position that will not be picked up by the antibody. So we always reflex negative immunohistochemistry to PCR. And this is an example of how we could use this diagnostically. Here it is, a compound lesion with some worrying pagetoid cells, but these are very epithelioid, could be Spitz maybe, or not. And these are our small immunohistochemical panels. So the first three are antibody for translocations, they are negative. The fifth one is the BAP1 expression is preserved, and this tumor has got BRAF expression. So we are no longer thinking of Spitz here, we are thinking that this could be an SSMM, and interestingly, the dermal component, we can see it here, is actually negative for V600E. So maybe this is a tumor that is evolving where only the junctional portion is evolving into SSMM. Okay, so another area is colorectal cancer, another big area where BRAF V600E could be useful. We know that this mutation is present in these colonic cess-ulcerated polyp or adenomas in a very high proportion of this. And these would be the precursor lesions of those colorectal cancer that have island promoter methylation, and they are deficient for mismatch repair. And a small number of cases arrive there not through this route, but through mutation in other pathways. And that's an example, perhaps, of a rather sessile lesion that start to get this dilatation of the base of these crypts. So this is a sessile-ulcerated lesion, and if you look at the expression of here MLH1, this lesion has lost it. So that's the pathway, and V600E will be useful in your diagnostic workout of this, but also in the tumors that arise from the invasive tumors that arise from it. So we know that everybody does mismatch repair. It's mandatory to have mismatch repair status for this colorectal cancer. So we know that there are more, but there are at least three important groups that are divided according to the BRAF status, the mismatch repair status. The deficient tumors that are wild type for BRAF have the best outcome. The proficient tumors that have mutated BRAF have the poorer prognosis, and then these are the intermediate ones. And I think these are not really very important thoughts, but therefore, in the context of colorectal cancer, then having this tool available where you don't have to wait for 2 weeks until these results come back, but is there with you immediately, together with the mismatch repair studies, etc. This could be very important because it can instruct MDT or tumor boards into making treatment decisions.
Absolutely.
Incidentally, we all had the problem of what do we do with those cases where we find mismatch repair deficiency, because some of them could be syndromic, the majority is not syndromic. Yes, we should do methylation, promoter methylation on MLH1. Not many of us have it in place, but we have learned that you can triage these cases to suggest that they may need a genetic referral or not by using BRAF. Why? Because maybe as we say here, 60% of sporadic MLH promoter methylation is associated with BRAF. So although this doesn't recognize all of them, only 60%, I'm going to enrich the population of cases that are potentially syndromic Lynch syndrome. So our little scheme is that if you lose one or more markers, you do a BRAF V600E, and if it's negative, you are telling your clinician that you should consider referral for further investigations. If it's positive, only 1% of the syndromic patients have BRAF mutations, so it's unlikely that you need referral to genetic.
We also need to point out, I think, that it works very well with the pair where MLH1, PMS2 are the affected pair, rather than the others where we should refer to genetics. Well, in any case,
more
to begin
investigation. Yeah, fantastic. And here are some examples. This is a little biopsy of probably a superficial biopsy of an adenocarcinoma, and here is the BRAF, and you can see quite nicely how it can delineate the invasive tumor. Here there are some normal glands that are not staining. This is higher power. So let's start looking at these pictures more in detail. So, I mean, you realize that there is some background staining even in the normal. You see these very small dots, and these are probably non-specific deposition of thiamides, and you can see also very faintly in the stroma. So you can have these things, and you need to understand how to interpret this. You know, this is an ideal situation because here you have the clear or very little staining in the nucleus, then a relatively good cytoplasmic staining, and an emphasis also at the border of the cells, and you know, this kind of staining intensity. We will see some pictures also to show that sometimes the antibody stains mucinous substances at the apex of the cell, and you need to be wary of that. So that's another case of a small biopsy again, demonstration that you can easily read this, and here you can see the mucin very positive. This doesn't mean that the cell is positive. You need to be wary of cases where you only have mucin staining. That's a non-specific finding. Here is a higher power, but interestingly, you can see here that the apical portion of the cells stains very nicely, and you can also see staining in between the cells. Yeah. And the contrast with the stroma is that the stroma is relatively clean. Sometimes the endothelium stains. So non-small cell lung cancer. Non-small cell lung cancer has a large number of cases where there are mutation drivers like KRAS, etc., but an array, and a much larger array than is shown here, of cases where a small proportion have other drivers. And BRAF is one of these other drivers, and depending who your patients are, some people say 6%, some people say 8%, some people say 3% of their population have mutant BRAF as a driver. Now, in the context of us chasing ROS1 0.5% and ALK maybe 2%, etc., this is not a bad number. You know, it's a significant number. These mutations are actionable. Well, not all of them are actionable, but now 50% of these mutations are actionable, are actually in the V600E, and they are actionable. So there are other mutations, it doesn't matter. And interestingly, the presence of this mutation is important for the oncology because it's a mechanism of resistance to EGFR tyrosine kinase inhibitors. So even if this was a non-small cell lung cancer with a EGFR mutation that is actionable, they would not respond because of BRAF. And so it's worthwhile looking for it. Also, because presence is prognostic, not just predictive. So poor prognosis for tumors that harbor the V600E mutation, and also worse response to platinum doublets. So it's kind of interesting.
So important even in chemo. Yeah.
Yeah. Oh, yeah. So obviously these are all the cases where patients are treated as first line because they had advanced disease. But now, importantly, now also for the operated patients, they start to use these things more because they give adjuvant therapy to these patients, and therefore the status of BRAF becomes important. There are other mutations, and some of them are activated and some are non-activated. 50% are non-V600E. But with this tool, we can find the 50% that are, and I think it's not an insignificant contribution. I think this is an example of a lipidic, if you want, tumor, where there is this accentuation of the maybe extracellular, I don't know, portion of the molecule. But don't worry about this. This will derail you. If you only look at this, will derail you. But you can see that also the cytoplasm is staining, and also between the cells there is staining. So this is a case that is BRAF positive. Okay, papillary thyroid carcinoma. I didn't know that, but apparently we knew that BRAF V600E is present in papillary thyroid carcinoma. At the beginning was all papillary thyroid carcinoma V600E. Now kind of we are saying about a little bit more than half. But interestingly, those that are induced by radiation, and there is a large cohort from the Chernobyl nuclear accident, they have fusions, not mutations, point mutations. So one of the ways in which this antibody could be used in triaging FNA samples. So this is a small microbiopsies for an FNA. You can see the papillary, maybe a bit here, the papillary lesion here, and you can stain it with the antibody, and you get a confirmatory diagnosis. And that can be quite helpful in managing these patients. Remember though that 40% or 35 or so percent will not have V600E, so a negative finding needs to be weighed up.
There are the lesions that are BRAF V600 even in the thyroid. So
yeah, this is
Corrado.
Yep.
There is a question in the chat. So if immunohistochemistry for BRAF V600E is sufficient to identify mutation, or is it necessary to perform also molecular test to confirm?
Yes, thank you. So the antibody, we haven't really spoken about this because the antibody is it's created against an epitope that is only available once the molecule is folded in the open position and activated. So this is not an epitope that exists in the normal molecule. It only exists in the mutated molecule. And therefore, non-mutated BRAF is not staining. So finding the mutant protein is equivalent to finding a mutation. So we can proceed to treatment without doing confirmatory sequencing for that.
Yeah, as long as the labeling is, maybe you talk about more about labeling is
Yes.
granular and moderate and
Yes.
strong rather
Yes.
than.
And so that's where the interpretation becomes important, because while for diagnostic purposes, you may or may not be very stringent in interpreting this antibody, you need to understand that when there is therapy selection at the end of it, you need to be extra certain that you are not reporting on cases that should not be reported, because there are a number of cases for a variety of factors, or pre-analytics, difficult interpretation, where you cannot push the envelope. You will need to say indeterminate, I will reflex to another test. Cool. Okay, that's a case of, another case of thyroid FNA, but this is BRAF negative. We will need to do more work. And there are a few more notes to say. For instance, histiocytosis of various types are high incidence of these mutations, and hairy cell leukemia. That's just a fantastic disease, because it's 100% BRAF V600E mutated. I don't know if this is ever true in biology, 100%. I don't know, but very large numbers. That's very good. This would be a great disease. I would become a specialist in hairy cell leukemia, because all I have to do is use the antibody and I get the diagnosis. But unfortunately,
Not specific.
No, unfortunately, they never biopsy hairy cell leukemia. Hairy cell leukemia is not a diagnosis that come across the histopathologist, so that's a shame. Okay. So let's talk about, well, what's also pertinent to the question we receive, interpretation and reflex into second test. So here are some examples. This is colorectal cancer, I think, and you can see there is strong staining. You can also see there is some staining here in the smooth muscle, and the kind of wishy-washy staining here and there. So smooth muscle, here it is, in contrast with the invasive carcinoma. The smooth muscle in this particular case is staining. You can see this granular, quite coarse intracytoplasmic staining. There's very little staining in the intervening connective tissue. So this happens. It doesn't happen in all cases. It may be related to the processing and preservation of the tissue, but be aware that smooth muscle can stain. So you need to take this into consideration. This is another case. This is the same case where you can see that there is also fine granular staining in these infiltrate, this immune infiltrate. And likely the contrast with the tumor is quite strong. The tumor is overexpressing it, and you can see the clear nucleus and the perinuclear condensation of this staining. So possibly we can make a diagnosis despite this amount of non-specific staining. So this was reported as positive for mutation. That's another case. You can see much less intense staining. This, I think, is a fault of normal mucosa. The muscle doesn't stain very much. Here is the intervening, rather non-specific staining in to a much less extent. And this is the tumor opposed to the normal mucosa. So you have a lot of pointers that give you more confidence in diagnosing this mutation. You can see that there is a little bit of non-specific staining also in the connective tissue, but overall, probably you have enough cases, enough to report as positive. There's another case where
interesting. So that's a pitfall. It has various areas of.
Indeed. And then look at this.
Different intensity.
And look at this bit here. And yes, different intensity. So, and then I photographed this bit here because this is clearly not staining. There's something wrong about this tissue. And this is what the staining look like in many areas. It's a little bit granular and maybe intracytoplasmic, but it's not to the extent that we've seen in other cases. So, and some of it is there is a lot of this retraction artifact. This is called pore preservation, and some of this is kind of granular and like it's been making little balls of retraction. And so I'm not entirely sure how much you can trust this staining here. However, in the same section, if you look around, you find areas that are better preserved showing this picture. Now, that probably is enough for you to say it's positive for V600E despite the poor preservation of the tissue. Yeah?
Yeah, I agree.
That's a case of non-small cell lung cancer. These are true cut biopsies. That's the tumor. And this is the appearance. So looks like positive. This is a higher power. Looks positive. What do you think?
It looks like it's a lot, the nuclei are picking up a lot of staining,
Yes.
which is unusual and non-specific for
probably non-specific. Okay, so that's very good. So this is a pitfall that you need to look for. So there is clearly something here that doesn't adapt. This is not a nuclear staining. No doubt somebody will demonstrate that in certain cases, BRAF will translocate to the nucleus. We are not aware of it at the moment, and it must be rare. And if you find it in your slides, you don't go for the rarest opportunity to make a diagnosis. You say something wrong. Here is another high power, another field. You clearly, there is a lot of nuclear staining. You can't ignore that. You can't say, yeah, I know there is nuclear staining, but there is also cytoplasmic staining. Don't go there. I think this was indeterminate with face of PCR. PCR, in fact, found no mutation, you see? So this is an antibody that you can use well, providing you understand the limit of the immunohistochemistry. Okay. A few more cases before we finish. That's melanoma. Kind of some staining. Let's go at higher power. Let's go at even higher power. That's not enough for anybody to do anything. This cannot be positive, but it's not really negative. What if this had V600E and for a series of circumstances, tissue is poorly preserved, the antibody doesn't stain?
Or interestingly, I've had a few cases like this, especially melanoma, that were BRAF V600K positive.
Yes, but don't start putting in people's mind that a low-level expression means K. It doesn't mean K. Yeah,
it doesn't mean that.
But that's interesting. So my take of something like this is this staining is very likely to be non-specific. I cannot tell you definitely is negative. So I need to report, I need to do PCR. And these melanomas, we always do PCR because we cannot detect the other mutations. And in fact, this did not have mutation in BRAF, but it had an NRAS mutation. Okay, so that's another example of a melanoma ulcerated, this time staining red. Not sure why, but again, with the red chromogen, this is very confident to make this diagnosis. Yeah. Let's see if I have other cases. That's another case of melanoma. So you see, often or almost always, the changes are diffuse.
Yeah, I think we had very few indeterminate cases, I would say.
Yeah. And so you see the diagnoses are easy because it's an all or nothing. And again, good demonstration, no nuclear staining, strong cytoplasmic staining, mutation detected. And this is a diagnostic case. Here it is, a epithelioid nested intraepidermal proliferation with maybe some dermal component, maybe elsewhere. The epidermis is hyperplastic, could be Spitz.
Yeah,
for all we know, large nests. So this is V600E. This is positive. So there it is. You know. So this was reported as SMM. You know, we stopped considering that this could have possibly be benign. I can't remember the context. This probably was in an older person, etc., etc. So depending also on the clinical setting, you may use different discretions, different interpretation. I don't know whether this is the last case. Looks like the last case. Okay, so we are in good time, 5 minutes till the hour. And we could go back to the audience for a 5 minutes question and answers.
Thank you, Corrado and Adelina. So please feel free, everyone, to ask questions. You can put it in the chat, and in that case, I will read them. Otherwise, just unmute yourself and participate in the discussion.
I'm curious to know from Emilia. I'm sure you have lots of things to add. I'm curious to know which areas you would like to comment on.
Well, I think for me, it's really, I think BRAF is a very useful tool. My challenge is really to decide, in which situations with regards to molecular. So for the turnaround time, when is it enough? How much do I need to, continue if I don't get so about the workflow, essentially, that's where I struggle the most.
So for instance, in colorectal, it's kind of difficult in colorectal because we also need to do KRAS, that's most important, and RAS, not just BRAF. And now some of the PCR kits include all of these molecules together. So you may want to use PCR to do this analysis. But on small, usually that's done on excisions. On small biopsies, where we need to do mismatch repair, we do use these quite readily once we find deficient mismatch repair. It gives prognosis, and it also gives an understanding of whether they should think about referring to genetics for these patients as well. So for colorectal cancer, that's the way we use it. For melanoma, so more recently, there has been an understanding that all those stage 3 melanoma, PT3, need to have a BRAF determination. We actually do it on all invasive melanomas and also lower stage, and is a very quick way of doing it. It is actually, it doesn't delay the report because it comes together with your other immunohistochemistry, which most of the time you do because, it's kind of, you want to do some immunohistochemistry on most of these melanocytic lesions. And that means that your report goes to the MDT with all the data. It doesn't need anything else. And in melanoma, we do reflex all the negative BRAF because we know that a proportion, maybe about 10%, are non-V600E mutations, which need to be identified.
So you stain on all melanomas, and if negative, you reflex to confirm.
Like
and there's a question. There's also a question.
Sorry.
No, related to that, because there's a question if you also routinely use BRAF to discriminate between benign and malignant melanocytic lesions.
No.
Adek will talk about it.
This is exactly what we're kind of trying to say, that BRAF mutation in melanocytic lesion is a very common occurrence, and we see it in nevi. We see either, and we have a lot of these cases are superficial spreading melanomas, and we see the nevus, the melanoma, and it could be the nevus mutated, the melanoma non-mutated, or the other way around. So BRAF doesn't tell you whether a lesion is benign or malignant. And now it's been quite a recent paper showing that there are lesions, just like we call BAPomas, so BRAFomas, which are BRAF mutated melanocytic lesions that have intermediate morphological features between benign and malignant. So we're not even talking about nevi, which we should put aside as benign, and they can be BRAF mutated, but it gives us an idea of pathway. So it kind of distinguishes conventional. We can see that in all sorts of, melanomas in sun-exposed skin as well, from Spitz or other more special pathways. So this is what it gives us an idea of lineage, which helps with the diagnosis to kind of put the melanocytic lesion in one of these boxes, more like conventional superficial spreading versus Spitz versus deep penetrating versus blue, etc., etc.
Yeah, I have one very, very short question, and then we need to close because we are at time. But my understanding then is that you do use it in those situations, but it more gives you the information on the pathway. But my understanding was also that especially in Spitzoid lesions, it might be more helpful to determine between a Spitz melanoma and a Spitzoid lesion.
Yes, I think so. I think if you have a Spitz nevus or Spitz tumor, as you want to call it, BRAF mutated, you really need to think long and hard that you want to make that diagnosis. It would be against the grain of any other pathologist. That's not a Spitz tumor. It could be something else, or it could be a spitzoid, a Spitz melanoma, a spitzoid melanoma.
I think the confusion is between spitzoid, which refers to a morphology, and true Spitz, which Spitz is a lineage, basically, is a lesion with other pathways.
And this is kind of important. It's now become important to firm up the lineage of differentiation of these cells so that you can then more confidently make a diagnosis. And that's kind of interesting. And of course, this is a small tool. There are a lot of other tools, other tests to do, but I think it's quite an important one. So, we certainly use it extensively. We wish it wasn't so expensive.
I hear you. Okay, with that, we are at time. I really want to thank you. This is a super exciting area, but it also requires some knowledge to be able to navigate it. I deeply understand when I listen to you and BRAF experience. So with that, any final words from you or before we close?
No, as you know, everybody probably know, now we are getting this BRAF circulation live. There are not very many cases, probably about 6 cases, some melanocytic and some colorectal. And it's just an excuse to start looking at this proficiency testing circulation with a broader spectrum and trying to bring into the normal use some of these markers that have been used only by a few laboratories in the past.
Yeah, so that's excellent. And so we invite everyone to participate and score these cases, and you will also be provided with how your score is compared to the consensus score. So have fun with scoring BRAF, everyone.
Very good. We'll see you all in 2 weeks' time for the feedback. Thank you.